You can find them at the bottom of your screen. This poll just went live, and we have 4, I believe, different questions for you to answer. So if you click on the little polls at the bottom of the screen, you should be able to see those 4 questions and then answer accordingly. So the first question is, what is your role in the myeloma community? We have patient, care partner, both patient and caregiver are here today, oncology nurse or doctor, and then other. Have you heard of MRD? Yes, I understand it. Yes, I don't understand it, or no. Have you talked to your medical team about MRD? Yes, I have. No, I haven't, or I can't recall. And have you ever received an MRD test? Yes or no. So people are very quick to answer. I'll give a couple of results since those watching the recording won't be able to see this, just so they have a good idea. Looks like we have the majority of patients here sitting at 76%, as well as some care partners, some both partner and patient and caregiver here, a couple oncology doctors or nurses, and other myeloma community supporters. Lots of people, about 61% has heard of MRD and understands it. 6% has heard of MRD but doesn't quite understand it, and 3% have not heard of it at all. 71% of attendees today have talked to their medical team about MRD, and 28% have not. And then 53% of people have received an MRD test, and 47 people have not. So I'll keep that poll live for a little while if those who haven't participated would like to participate. But that's really great information, I think, for us to get started with today, Robin and Mark. So the time is now yours for your presentation, and Dennis and I will turn off our cameras and see you at the end of this. So thank you.
Wonderful. Well, thank you so much, Audrey. Speaking for Mark and I both, we're thrilled to be here. We are so appreciative of our partnership with Myeloma Crowd. And so just thank you to all of you. We really appreciate you, and all of you out there coming to listen today. Thank you for joining us. And we're thrilled to be here to talk about minimal residual disease. And so as Audrey mentioned, I am Robin Dullea, Associate Director for clonoSEQ Marketing at Adaptive Biotechnologies. And I have a little bit of introduction information that I would like to share before we get started. So clonoSEQ is an FDA-cleared test used to detect minimal residual disease in bone marrow.
Robin, sorry to interrupt. We can't see your screen if you're trying to share it.
Awesome. Thank you.
No problem. I just wanted to catch you before you got too far into it.
So glad that you did. Thank you. Can you see it now? Can you guys see it okay?
No, do you want to try it again?
Okay. Let me try again. Share. Thought I had. Okay. What about that? Did that work?
Yeah,
it looks like
seems to be working.
Okay. Thank you. Thank you so much for bearing with me. So as mentioned, I need to share some important information about clonoSEQ, and it is an MRD test to measure measure MRD in bone marrow from patients with multiple myeloma and B-cell ALL, and blood and bone marrow from patients with CLL. clonoSEQ is available also for use in other lymphoid cancers as a CLIA validated laboratory test, developed test service. clonoSEQ is only available by prescription from a licensed healthcare professional, and results may vary. Talk with your healthcare provider to see if clonoSEQ testing is right for you. For important information about the FDA cleared uses of clonoSEQ, including test limitations, please visit clonoSEQ.com/technical summary. And with that, I will hand over the microphone to Mark to share the MRD overview.
Thank you, Robin. Thank you, everybody, for joining. And I'm going to give a little bit of an apology. I'm getting over a cold and have a bit of a cough. So I apologize for any coughing, and I'm probably going to have to stop to take a drink periodically. But very happy to be here. As Audrey mentioned, I'm a senior medical science liaison for Adaptive Biotechnologies based out of Seattle. Been with Adaptive for roughly 2.5 years, I've been either an oncology researcher or medical science liaison for the past, I guess, around 15. And so I'm very, very passionate about oncology. And I'm really excited to be here to speak with you. And with that, let's go ahead and jump into the next slide. Thank you. So a cancer diagnosis is never easy. And you don't need me, or this audience does not need me to tell them that. But what I can say is that being anxious, overwhelmed, or confused is a perfectly normal part of the experience for both patients and caregivers. And what is also normal is wondering how the progression, how treatment is going, how you're responding to treatment, what is like if you may be relapsing, what is the prognosis for your disease? And so, MRD, minimal residual disease, and testing of is something that can help answer these questions. And thank you as we get into the next slide. And so what is minimal residual disease? And I guess I want to start by kind of stepping back is a lot of the time people think that minimal residual disease is something that is very complicated, and it can be, but at the most basic level, it's assessing how much cancer is present in the body. This is something that has been done really since we were able to treat cancer. It's been important to understand how much cancer tumor is remaining in the body. And so from and when we talk about MRD, in the current day, it's really just an evolution in being able to detect a minimal or measurable amount of residual disease. I actually personally prefer the term measurable residual disease because as a great oncologist here in the Seattle area said, there is nothing minimal about residual disease. If we look over to the right, we have this iceberg analogy, although it is slightly reversed, at least based on size. But it's a good analogy because we start with, so at diagnosis, patients will have a large number of detectable cancer cells. And this is easy to observe, generally with a CBC panel just looking at number of blasts. But with treatment, usually and ideally, the disease burden drops. And for instance, with a complete response, which most of you are familiar with, which particularly relies on traditional clinical response assessments, a clinical response can frequently be achieved with disease burden levels of 10 to the minus 2 or 10 to the minus 3, which is frequently how we talk about MRD, but 10 to the minus 2, that is 1 cell in 100. One cancer refers to 1 cancer cell out of 100 normal nucleated cells. 10 to the minus 3 refers to 1 in 1,000. But particularly with modern treatments that are much more effective, that have come along in the past 20 years or so, most patients now achieve a complete response. And most patients achieve a level of disease burden that is much lower than could traditionally be detected. And this is what we're talking about. Usually when discussing MRD is we're talking about a level of disease that is somewhere in the range of like 1 cell in 10,000, or 10 to the minus 4th, down to 10 to the minus 6th, or 1 cell in 1,000,000. And so it's important, or I would say most physicians and researchers believe that it's important to be able to measure disease down to these much lower levels to get a better idea of what is actually happening with the cancer at a deeper level than what can be potentially achieved with a complete response. Can you go to the next slide, please? Thank you. So MRD testing is a powerful way to assess response to treatment and evaluate prognosis in lymphoid malignancies, of which multiple myeloma is one. So with lymphoid malignancies, as alluded to earlier, refers to the number of malignant B or T cells. For myeloma, the B cells that may remain in a patient's body during and after treatment, and which may eventually cause recurrence. So kind of the paradigm, so start at diagnosis in this left panel where you see the cancer cells would be colored pink with the normal cells as blue, and you can see that maybe half the cells are cancerous. Then with treatment and then remission, the cancer cells go away and are not observable, but then over time will frequently relapse. And as I'm sure most of you know, that with myeloma, it does frequently recur, hopefully after many years, but it does recur. And so in this case, so waiting for clinical relapse or sign of symptoms is how this disease used to be monitored. But with newer technologies like MRD, we can potentially be able to monitor for relapse at a much lower disease level, and so potentially catch relapse much earlier with a much lower tumor burden before the disease becomes asymptomatic and when it may potentially be easier to treat. Next slide, please. So there are several ways, common types of tests that are available, and so all of these are frequently used in the course of treatment for multiple myeloma. And so I would actually say that when you're talking about MRD, the flow cytometry and the next generation sequencing is what's usually being discussed, whereas with microscopy and PET-CT are also measures of methods of assessing disease. In kind of common vernacular, they're wouldn't necessarily be considered to be MRD, but they are methods of measuring disease burden. And so on the left, with microscopy and flow cytometry, both of these measure, directly assess cells. And so microscopy, just by a pathologist looking at cells on a slide, with flow cytometry, can be used to assess large numbers of cells, hundreds of thousands to millions of cells at a time, and also look at expression of particular markers which may be relevant to your cancer. PET-CT is frequently done with myeloma and other diseases to look for lytic lesions or areas of potential tumor. As we're all aware, myeloma is a patchy disease, and so it may be possible to have small patches that could be missed with other assessments. And so imaging is frequently done in conjunction with other disease assessments to look at the whole body. And then finally, we have next generation sequencing, which assesses at a molecular or DNA level to look at directly at the DNA, whether for such as clonoSEQ, looking at these rearrangements that associate with a given cancer, or in some diseases, looking at particular mutations. Okay, next slide, please. So why are we interested in MRD? Well, first of all, MRD is one of the strongest predictors of outcomes in blood cancers. It's actually true for myeloma as well as ALL and CLL. That in a large number of studies in myeloma, MRD negativity associates with better outcomes. And this is particularly important now because newer treatments, we've had so many new treatments come along in the past decade, and these are helping patients live longer, and patients are getting into much deeper remission and to a level that wouldn't have been possible of cancer that wouldn't have been possible to detect with previous technologies. But with MRD testing, with an MRD testing methodology that has a very high level of sensitivity, can get a much better understanding of how a patient is responding and how their cancer is responding to treatment. Additionally, it is, I guess I will throw out that it is important to consider and have a discussion with your physician about the type of MRD testing that is being done, because not all MRD tests are created equal, and not all MRD assessments from place to place are created equal. But this is a discussion that should definitely be done in conjunction with the patient's care team. Okay, next slide, please. Excuse me. Like I said, I was going to cough and then need to take a drink. So how can MRD be useful to you and your doctor? So MRD is frequently used at multiple time points in the treatment journey. And so this is kind of how we frequently envision MRD, depicted on a graph rather than pictures I showed previously, but with diagnosis, high level of treatment is initiated, cancer level drops, hopefully becomes undetectable, and then over time, disease may relapse. And so with MRD assessment, it can be helpful for being able to predict long-term outcomes, as in providing prognostic data for what the likely outcomes, say, after initial induction therapy, and assessing response to treatment. Can be used to track disease burden over time, and for instance, ensure that the patient is indeed remaining MRD negative. And then in addition, if the disease does relapse, be able to detect potential relapses prior to patient becoming symptomatic or having clinical relapse. Okay, next slide. MRD is included in both the NCCN and IMWG criteria for multiple myeloma. So MRD testing is recommended at multiple time points during and after treatment. From the NCCN guidelines, does recommend getting, or I should say, recommends or suggests considering getting a baseline clone identification for MRD testing by NGS. So for clonoSEQ or NGS testing, having a baseline clone or having a sample from diagnosis or time of relapse is necessary for being able to effectively track the tumor. And so this is suggested that it should be considered as part of the baseline workup. And then it's also recommended to consider testing after each treatment phase. So after induction, transplant if indicated, consolidation, and maintenance, and then potentially also periodically during maintenance. But once again, a decision that should be discussed with physician. So with that, I will turn it back to Robin, and she can go through the clonoSEQ overview.
Thanks, Mark.
You are welcome.
I am excited to share the clonoSEQ overview with you all. So clonoSEQ is the first and only FDA-cleared test that detects, counts, and tracks MRD in bone marrow samples from patients with myeloma. And with clonoSEQ, you and your doctor can monitor your cancer by assessing treatment response and detecting changes in disease. And you and your doctor can also then have a personalized way to track and talk about your body's individual response to treatment. And knowing how much cancer still may be in the body may allow you and your doctor to better tailor your care to respond to changes in your disease level. clonoSEQ also enables you and your doctor to manage decisions with an ongoing understanding of your long-term outcomes. And while remission is a relief for many patients, it may be accompanied by a feeling of uncertainty. And your doctor can use clonoSEQ to see if any cancer cells are returning. Regular MRD assessment may help you gain confidence in understanding how your disease burden is changing over time, and so that you can move forward with confidence and planning for all of life's moments. And even if you aren't experiencing any symptoms, you may worry that the cancer will return, and detecting physical, and you can detect physical signs. You can detect with MRD the return of the cancer before physical signs and symptoms arise. and that allows you to confidently plan for the future. So how does clonoSEQ work? clonoSEQ measures MRD by identifying the specific DNA sequences associated with the cancer and then tracking them over time. And throughout treatment and beyond, samples can be collected periodically in order to monitor changes in disease. clonoSEQ looks at the bone marrow sample collected at diagnosis to identify the specific DNA sequences, and this is sometimes referred to as the clonality ID. Using the clonality ID as a baseline, clonoSEQ MRD tracking can be used to detect even down to one cancer cell in a sample of 1 million healthy cells. So you and your doctor can be confident that you know if residual disease is present. So how does clonoSEQ know what to track? Humans, as we all know, have billions of blood cells in their bodies, and each white blood cell carries its own DNA sequences. In people who do not have cancer, each white blood cell is present at about the same level. So as we see here, for example, the number of cells in each of these columns, A, B, C, D, and E, and showing their related DNA sequences would be roughly equivalent. In people with lymphoid cancers like myeloma, the cancer cells, which are abnormal white cells, reproduce faster than the healthy white blood cells, and each cancer cell with the same DNA sequence is called the clonal cell. And identifying those at the beginning is what provides the clonality ID that then later is tracked against. The clonoSEQ report, which goes to your doctor, provides helpful information about MRD, including showing the MRD status, which is depicted as a positive result, which is shown as a plus sign. A positive result means residual disease was detected. A negative result shown as a minus sign means no residual disease was detected in the sample. Setting a goal of MRD negativity might be right for some patients, and you can talk to your doctor to find out if it's right for you. The MRD level is the amount of cancer-related cells detected in the sample, showing how much disease is present. So it's the quantitative amount of cancer cells. And your doctor can help put this number into context based on your current phase of treatment and your therapeutic goals. The MRD trend is the graph that shows the changes in the MRD level over time. And so watching these changes will help you and your doctor understand your response to treatment and track changes in your cancer. And regardless of your status at any given point, valuable information can be gained with clonoSEQ testing to understand where your disease burden stands at any certain point. So how can knowing your MRD status help you manage decisions along your cancer journey? Monitoring MRD to detect changes in your disease can show how well the treatment is working. And knowing your MRD status together with other clinical information can help inform future decisions at key points in your care, such as following induction and consolidation therapy, or after stem cell transplant, or during and after maintenance therapy, and also detecting returning disease with routine MRD testing, and then finally throughout the course of relapsed refractory therapy. So clonoSEQ has wonderful coverage. clonoSEQ testing is covered by Medicare and private payers, and it's nationally available and is covered at multiple time points throughout the disease journey. 90% of patients actually end up having no out-of-pocket costs for clonoSEQ testing. So it doesn't end up costing a lot, which I think is sometimes a little bit of a surprise for people. But if you're wondering about potential out-of-pocket costs, which everyone I'm sure would be, we have the Adaptive Assist Patient Support Program. It's available to provide comprehensive support to patients throughout their clonoSEQ MRD testing journey. Adaptive Assist is available to help patients understand and navigate their insurance coverage. And so they do that by providing upfront out-of-pocket estimates and prior authorization management. They can appeal for maximum benefits and the lowest possible out-of-pocket costs. And financial assistance can be provided for the remaining out-of-pocket costs for qualifying patients. Enrollment in Adaptive Assist can be done in as little as 5 minutes, and it's worth doing if you think you're going to get a clonoSEQ test, or you have gotten a clonoSEQ test. They can help provide information that would be helpful. Finally, for more information about clonoSEQ, there's a lot more information available at clonoSEQ.com, including different materials like the clonoSEQ patient brochure and the doctor discussion guide and the Understanding clonoSEQ guide and the MRD fact sheet and much more. There's many other resources to learn more about MRD, and certainly Myeloma Crowd has tons of information about it. And of course, HealthTree University has an entire module on MRD with videos of myeloma experts discussing its role in clinical trials and in clinical patient care. So to learn more, I encourage you to go there as well. And with that, I think we're ready to have some questions, Q&A.
Perfect. Thank you so much, Robin. If you want to stop sharing your screen, so perfect. Awesome. All right, so let's get started with some frequently asked questions. And again, you can ask your question to Robin, to Mark, to Dennis, or to all of them. Just know that these three panelists are here to help you. So one of the first questions is, how does MRD status help inform myeloma management decisions? So I have my MRD results. Now, what do I do with my treatment? What's my doctor going to do? Dennis, I think this one's probably best for you.
Absolutely. Before I start, I just want to thank the Myeloma Crowd and Adaptive for inviting me to be part of this Q&A panel. I'm very excited to be here, so thank you so much for the invite.
Mm-hmm.
So to answer the question, so the MRD testing is very important, and we use it a lot in our clinic to kind of guide our clinical decision making. So for example, we like to do MRD testing after induction therapy. So we like to give about 6 to 8 cycles of induction therapy, and then we like to recheck a bone marrow biopsy with MRD testing. And depending on what those results are, will sort of guide us of what we're going to do with the next steps are with the patient. So for example, if we do a bone marrow biopsy with MRD testing after, say, 6 to 8 cycles of induction therapy, and the patient is MRD negative, okay, and they're transplant eligible, the way we practice is we think it's very reasonable to collect stem cells, store them in the freezer, and then go right to maintenance, a maintenance regimen. If the patient, say they're slightly MRD positive, so there's different levels of MRD positivity, right? So you can have just barely some abnormal cells, or you can have more higher burden of disease. So we'll split those into 2 categories. So we'll take the patients who are just barely MRD positive. And for these patients, there's a couple of different routes that you can go. Typically what we do in our clinic is after induction therapy, again, they're slightly MRD positive. So we're going to take the slightly MRD positive patients. We would collect stem cells if they're transplant eligible. And then from there, there's a couple of different routes that we can go. We can they can opt for transplant, which is reasonable. We can do some consolidation therapy with a different regimen, or if they're still responding to the induction regimen, we can maybe just add on a couple of cycles of what they're already getting. Or I think it's very reasonable if the patient has very, very little bit of disease, collect stem cells, and you can also still go to maintenance with those patients. So you can treat those patients who are just barely MRD positive almost the same way as you would treat the patient who's MRD negative. Now, for the patients who have a little bit more higher burden of disease that are MRD positive, for that, I would not recommend to go straight to a maintenance regimen if they have a significant amount of disease still left in the marrow. So in that case, we would recommend that we still collect stem cells if they're transplant eligible. And in that case, we may want to switch gears to maybe a different regimen to drive down the disease a little bit more, and then restage again with another bone marrow, say after 2 to 4 cycles, and then assess again for the MRD status.
That was great. Thank you so much. And I think that was very clear how you explained it as well. So thank you. The next question is, how important is it to achieve MRD negativity? I think in a lot of the patient population that I've talked to, it's kind of the ultimate goal, right? Is to get this MRD negativity. And how would you guys respond to that question? Is it important to achieve MRD negativity, and what happens, or what does it mean if that goal is not reached?
Oh, go ahead, Mark. I'm sorry.
Yeah, I would say I can start with that, and I guess I'll give the reminder that I'm a PhD, not a clinical practitioner. Nothing that I say should be taken as medical advice, but I can speak broadly to the data. So there is a very strong consensus that in general, patients who achieve MRD negativity are going to do better. In fact, there was a recent meta-analysis that looked at 44 different published studies of MRD using different technologies, different treatment regimens looking over the past decade. And I think nearly every study of the 44 showed that if patients that MRD negativity associates with a better prognosis, and that achieving a deeper level of MRD response also associates with a better prognosis. This is largely true whether you are in studies for newly diagnosed patients. It's true for relapsed refractory patients, and it's largely irrespective of the treatment. In that studies say, for instance, comparing two studies I can think of off the top of my head that were both looking at Dara and tumumab in combination, but that it was if the patient achieved MRD negativity with or without the daratumumab, their outcome was very good. The vast, many more patients achieve MRD negativity with Dara, which is why it is used, but that it's really getting to that MRD negativity for a lot of, that's come out in a lot, or what's been demonstrated in many studies is that it's the getting to the MRD negativity that seems to be the critical point for better prognosis. That being said, this is speaking broadly to data, and not all patients experience the same thing. There are patients who will achieve MRD negativity and relapse, and there are patients who may who may remain MRD positive for a long period of time without progression. But I think actually, I'm sure Dennis can relate that better than I can with patient experience.
Absolutely. Thank you so much, Mark. So yeah, you mentioned, and you make a great point, Mark, that it doesn't matter how you get there. We're seeing, obviously, we're giving more of the antibody upfront, the daratumumab, and we're combining this with more of the traditional regimens. So the Griffin study looked at, giving Dara with RVD, so Dara, Revlimid, Velcade, dexamethasone. And in that trial, they had about 50% of patients achieve MRD negativity. And I believe that there was a transplant also included in that data, plus 2 more cycles of Dara RVD. And then we also had the Manhattan trial at Memorial Sloan Kettering when I was there with Dr. Langren. And we were able to combine daratumumab with carfilzomib, Revlimid, and dexamethasone. And this was without transplant. And we give these patients 8 cycles of therapy, of induction therapy. So this is for newly diagnosed patients. And the MRD negativity rate was over 70%. It was about 72% of patients reach MRD negativity. So you make a great point, Mark, that it doesn't matter how you get there. So I think the long answer is, or the short answer, I should say, is that for patients who achieve MRD negativity, the goal when we treat a patient, and this is in the upfront setting, this is in the relapse setting, whenever we put a patient on any regimen, the number one goal is to try to eradicate all of the disease. That's the number one goal. We hope that we can do this with every patient that we put on treatment. Unfortunately, we don't, but we're getting smarter and we're learning new strategies on how to achieve that. But Mark makes a fantastic point that, and I've seen this clinically, that patients who are MRD negative, they tend to they have a progression-free survival and an overall survival benefit. However, I do want to make a point, and because myeloma, as we all know, has many, many, many gray areas. So there's a lot of gray areas. This is not a very black and white disease. And I can tell you in my clinical practice that I have had patients who have never achieved MRD negativity and have always had this residual protein. So every time we did a bone marrow on them, they were always MRD positive. And that protein it wasn't an active disease. So that protein just kind of sat there and it just stayed stable over a very, very, very long time. And these patients tend to do just as good as the patients who are MRD negative. And just like Mark mentioned, there's also patients who have achieved MRD negativity who unfortunately have relapsed sooner than a patient who was MRD positive. So just to recap, the goal is always to eradicate as much of the disease as possible. We ideally would love to eradicate all of the disease. And this is anytime we give a regimen, but more specifically up front. And when we do that bone marrow after the induction therapy, we're hoping that we see MRD negative results. But however, as I mentioned with the last question, if patients still have a little bit of tiny disease, that little bit of MRD positivity can just sit there for a very, very, very long time. And patients can have a very durable remission on maintenance therapy.
Awesome. Thank you. I was muting myself because it's my son's bedtime and you can hear him screaming in the background. I wanted to follow that up actually with something because I've seen it be a psychological blow to a couple of patients when they realize, oh, I didn't achieve this MRD negativity. Mm-hmm. And there comes a point to ask, and it's a hard question because, like you said, myeloma is a gray disease, not black and white. Myeloma is an extremely unique disease. But is there a number? Is there a threshold? Well, if you just have this much, it's okay. But anything over this number is something that we should be looking more into.
Clinically, there's not really a threshold, but we know that when we do a bone marrow in a patient and we're looking at their MRD status, if we see patients that have just a little bit, a tiny bit of disease. So when you look at the MRD testing, you know, the patient's either going to be MRD, they measure an MRD negative or MRD positive, but there's also a level that is a little bit, so if the patient has a little bit more higher burden of disease, we feel like that's not the type of patient that we would want to take the brakes off, so to speak, right? So that's a patient we may want to push forward, maybe give the same regimen, give a little bit more therapy, and then maybe check again in another few months and restage with another bone marrow. But to answer your question, there's not really it really just depends on what the report shows. There's not really a magic number that we have to answer your question. It's not like you know, there's a threshold that we would look at to say, okay, we're going to do this or we're going to do that. We take it more on a case-by-case basis, if that makes sense.
Totally. Thank you. Another commonly asked question, I see it throughout the question and answers, so I figured I'd ask it, is how frequently should MRD be monitored? And we saw that question too as well, Dennis, about especially in that maintenance phase. Yeah. How often should this be monitored?
This is a fantastic question, and this is one of the big questions in myeloma, right? So we'll take a patient from the beginning. So patients newly diagnosed, they go through their induction therapy. We do a bone marrow, they're MRD negative. They forego transplant, they collect their stem cells, and we put them on maintenance. So each again, this comes down to you know, myeloma, a lot of gray areas, and also these different myeloma institutes will also treat slightly different, and they'll also use MRD testing slightly different as well. In our practice, what we would tend to do is we would put a patient on maintenance therapy, and we would like to check a bone marrow at the 1 year mark. And if you know, another big question in myeloma is you know, when can patients go off of therapy? So I'm gonna get there in a minute. But we would put a patient on maintenance. We would recheck their bone marrow. We tend to check bone marrows annually on patients. And of course, this is not set in stone. This is, again, another case-by-case basis. There's no data on how often to check. But in our practice, we tend to check annually on patients. So coming back to the golden question, or one of the golden questions in myeloma is, you know, if a patient sustains MRD negativity for, say, 3, 4, 5 years, at what point can you safely say that they can go off therapy? Well, the answer to that question is nobody really knows. So this has never been studied before. They're looking into this. There's a trial. I believe Memorial Sloan Kettering has a trial. I think they had it before I left there. That they're measuring patients who have sustained MRD negativity for I think it's 3 years. That they'll have the option to go off and be followed off therapy versus staying on therapy. But one of the big indicators for that is going to be MRD testing. So again, this is where it's very, very important to have this MRD testing. And this is just another example of how MRD testing is going to guide treatment decisions in the future. So this is a classic example.
Yeah, I love that. And thanks for bringing that up, that it's currently being, tested in these clinical trials. This is part of the research that is being done in the clinical trials right now. I see a couple questions about that in general. And so I hope that, we can continue to talk about it as this session goes on. Mark, I think I'll target this question towards you. There's a question about if the MRD testing of the bone marrow is reliable because of the nature of myeloma. I could take a sample from my hip, but who knows with myeloma that I don't have it floating somewhere else in my body and it wasn't detected. So how reliable is this bone marrow test, and how confident can we be in the test because of the uniqueness of myeloma, if that makes sense?
Sure. Yeah, and that's a great question. I can say when I started working in myeloma a few years ago, I was actually surprised because I didn't really know how it was tracked, in that you could do bone marrow, single site bone marrows on Apache disease and get good results. But you can, and the results are quite reliable. I'm aware of at least one study where that was done with myeloma patients, where they did bilateral bone marrows at the same time. And so that's a bone marrow, and I think it was in the pelvis. I don't know who volunteered for that study, but it was a great study, but it also demonstrated that even so, looking in two different spots in the body of a patient at the same time, despite the patchiness, the results were very similar. And so based on that study and others, the bone marrow assessment seems to be quite reproducible in myeloma, and the patchiness does not seem to be too much of an issue. I will say that being said, we always give the guidance, and this is stated very clearly on our clonoSEQ test report, is that MRD results, just like any other lab testing, should be taken in consideration with all available evidence for the patient. And so something that I know our one of our medical directors who does clinical consultations is, if there is something with the MRD result that does not jive with how the patient is actually presenting, then maybe you missed something. And so like MRD works very well, but at the same time, sometimes things are missed, just like with any other diagnostic test. And so it is important for all available data to be considered.
Awesome, thank you. All right, now we'll switch. There's several, well, not really switch, but move on to that next phase of questions, which is specifically about this original sample that people are having to get in order to do this clonoSEQ test. There's quite a few questions about it. And in fact, we even have somebody who is a little bit disappointed because the doctor said they weren't able to get a clone from the original biopsy. And so therefore she would not be able to have an MRD test. So is this true that without the original sample, you wouldn't be able to get any kind of MRD test? And what are the options for patients who have this situation?
Certainly. So I'll start just by talking about clonoSEQ, so clonoSEQ does require what we would call an ID or diagnostic or clonality sample. So usually that's diagnosis, but it doesn't have to be from diagnosis. It needs to be from a time of high tumor burden. So it can also be from relapse. And so if a patient relapses and the disease burden goes up, and there is a sample from that time, we can use that as well. It would just need to be from a time of high disease burden. I will also comment that we do have a group at Adaptive who is very skilled at tracking down original pathology samples. And that is a service that we provide. And I will say maybe not all physicians might even be aware of that, but if they submit the order to Adaptive, Adaptive will do whatever they can to help them track down that original sample. But if there is not a sample, either from diagnosis and the patient is not in relapse, then we would not be able to do clonoSEQ on the patient at that time, because we have to have that original sample to be able to identify the specific DNA sequence that is associated with that patient. And we need it at a we would say time of high tumor burden, because we have to be able to identify it because it relative in the background of all the normal cells. And so at usually at diagnosis, that could be 50% of the cells have this patient-specific cancer patient-specific sequence, or sequence that is specific to that patient's cancer. And so we have to be able to identify it when there's a lot of it there, so then we can later go back and pick that out when it's one cell in a million. That being said, if the patient does not have a trackable, or they cannot find the original ID sample, flow cytometry still should be available for the patient. And so they still should be able to get MRD assessment done just by another method. And so I want to make sure that everybody is aware of that.
Okay, thank you. And a couple follow-up questions with that. So you mentioned that if they're in relapse, they're not able to get, that clonoSEQ test. Not that I would wish this upon anybody, but if they were to have an aggressive relapse that resulted in a higher tumor burden, would they be able to get a sample that could be then used in the future?
Very likely, yes. So if the patient relapsed and a bone marrow was done, then could very likely be able to use that sample. And then so hopefully the patient relapses, we get an ID sample from that time, and then they go on treatment and they have a complete remission, and then we could track their MRD in the future.
Okay, thank you.
Welcome.
And then we have a question actually from a patient who's saying, how can I get MRD testing by adaptive or clonoSEQ? I requested this, but was told that there was no one within 50 miles that was doing it. Do you have to live close to a facility that's doing clonoSEQ, or how does this work?
Robin, do you want to take that one, or I can? Either one. Yes, I'm happy to take that. Yeah, that's a good question. On our adaptive or on the clonoSEQ.com website, there is a physician finder tool where you can put in your zip code and you can find out if there's other physicians in the area, or if you're looking in a certain area who offer clonoSEQ as a service. If your doctor though doesn't offer it and it's not available anywhere nearby, I don't know then how one would proceed there. I think it would just be you would have to talk to your doctor and the institution more about whether they'd be willing to bring the test in.
Okay, thank you.
It's their decision.
Yes, I will say, like, we are happy to any physician who wants to run clonoSEQ, we are happy for them to set them up to be able to run clonoSEQ, but not all institutions or practices do. And so, but yeah, a patient requesting would certainly help, I think, spur the practice or institute for signing on to do clonoSEQ.
Awesome, thank you. So we have several questions, actually. This surprised me, but talk about a defect. What about if their MRD testing results in a defective clone? Or let's see, no, I read that wrong, excuse me. The defective clone comes from the original BMB tissue, and so they're not able to get MRD testing. This happened in more than one patient that's here today. And I wondered if you guys have heard of that, and if you could speak to it if you have heard of that.
I'm sorry, I'm not sure I understand the question.
I've been told that I could not get MRD testing due to a defective clone from the original BMB tissue. Is this a permanent issue, meaning I can never get tested? Is it possible that the original BMB testing facility has more tissue in the storage? And then we have somebody else asking about, oh, I guess they're asking something different. I thought they were asking about clonality.
I'm not sure. BMB, I don't know.
Bone marrow biopsy.
Okay, bone marrow biopsy. Could you repeat the question one more time, because I'm not understanding it?
I'm sorry.
I think there's a if you could just repeat it.
Okay. And Dennis, if you want to pop in, if you have any ideas, because I'm not sure I completely understand it, but I do want to make sure we can answer if we can help it.
Sure.
So they say, I've been told that I could not get MRD testing due to a defective clone from the original bone marrow biopsy tissue. Is this a permanent issue that means I can never get tested, or is it possible that the original bone marrow biopsy testing facility has more tissues in their storage?
So, okay, so assuming that they're talking about clonoSEQ, I think there could be a couple different things that is going on. Is one, it could mean that their biopsy, like the DNA had that. If I actually saw the test report, for instance, or what they got back, I would be able to tell you. So it could be that they have a very old sample, and when it was submitted, the DNA was degraded and we could not run it, which we would call a QC failure. And so in that case, if another sample were obtained, then we very likely would be able to run clonoSEQ on that patient. The other possibility could be that it would be what was called a calibration failure. And so in a small number of patients, we cannot find what you would call a trackable clone. In that basically the DNA sequence that we are looking, or that is associated with that patient's cancer, is not very unique, and we can't distinguish it from background, and therefore we can't really do an effective assessment. And so in that case, if it is a case where they had a good sample, but it did not calibrate, or we could not find a trackable sequence, then in that case, they would not be able to use clonoSEQ in the future. But if it's a case where it was a bad sample, then submitting a newer sample or a better sample would potentially work. I think, based on the question, I think those would be the two possibilities of what the patient was referring to.
Awesome, thank you.
Welcome.
There's another question about how many years past original diagnosis can you collect the original clone? You talked about that it might be too old. How old is too old?
I mean, we don't, I guess, Robin, feel free to chime in. I'm not aware that we have any limit, because usually for the diagnosis, it comes from formalin fixed, paraffin embedded tissue, and those are very stable. And we're looking at genomic DNA versus RNA or proteins. That tends to be quite stable. And so there's really no limit from say that initial sample. There's no limit that I'm aware of, time limit, between that initial sample and what is at least worth trying. And I know that we have run some quite old samples, like a decade or more, and still been able to effectively find a trackable clone.
Great, thank you. 99% of the questions in our question box right now are about blood testing. Is this in the future of myeloma? People are kind of sick of the bone marrow biopsies and ready to see something different. When would we be able to see, is testing for MRD in the peripheral blood in the future for myeloma?
Yes. Yes, with some caveats. And so I can say that, we can run blood. Right now, we can run clonoSEQ on blood. But I want to caveat that with it is not quite the same use as for bone marrow MRD. And the reason is it's a matter of biology, in that so for instance, I'll throw out like CLL and ALL, two other lymphoid malignancies, both that both shed a lot of cells, a lot of cells make it from the marrow into the blood, and it's quite consistent. And so it's potential, so there's good potential for tracking cancerous cells in the blood. Myeloma, the biology is different. Because of the patchy nature, you see there tends to be a much greater disparity between the number of cancer cells in the marrow and what gets into the blood. And it tends to be more variable. And so, for instance, for ALL, we generally think that there might be a tenfold difference between bone marrow and blood. CLL is more like 3 to 5-fold difference. Myeloma, we think of it as like 100-fold, but from the data, it might be 10 to 1,000-fold. And so, for instance, particularly during COVID, we did have physicians switching to using blood for myeloma, but it was primarily because, so it is not as sensitive. If you assess in blood, it's not as sensitive, but if you're worried about going to the hospital for a bone marrow during a pandemic, it is a way to get an assessment. It's harder to interpret what a negative means, because if it's positive, then it's positive, and you know that and if you were negative before in bone marrow and it's positive in the blood, you know that you have disease recurring and should be acted upon in conjunction with your doctor. If it's negative, it's not as definitive just because the sensitivity is much less. But as I said, it's an issue of biology. We are working on it. We have several studies ongoing in blood. There are some other technologies that are in development, such as mass spec, that are also looking at assessment in bone marrow, but because they're testing something different than, like, clonoSEQ is a direct cellular assessment. We are counting the number of cells. Mass spec, which is another technology that's kind of in its infancy for doing a type of MRD testing for myeloma. It looks for M protein, and so it is potentially, from the initial clinical data, good sensitivity, but it isn't necessarily used. It can't necessarily replace kind of traditional MRD of direct cellular assessments, because M protein can hang out in the body for a very long time. It's very long half-life, and so the readings from mass spec can be maybe potentially misleading depending on where the patient is kind of in their treatment cycle. And so, I'm sorry, that was a very long-winded answer, but it's a complicated question.
Yeah, thank you. Thank you for that. Dennis, did you have anything you wanted to add there?
I just wanted to piggyback on the mass spec testing. So this is not approved, but we used to do this in New York at Memorial Sloan Kettering, where we would take a blood sample, and the way we measure a patient's disease aside from bone marrows is part of our myeloma blood panel consists of a serum protein electrophoresis and an immunofixation. So when you look at the sensitivity of mass spec, it's about 100 times more sensitive than doing our serum protein electrophoresis. So like Mark mentioned, I don't think this is going to replace bone marrows, but this is a nice little add-on test that we can do. It's very easy enough to do. They don't need a lot of sample. It's a very, very scant amount of serum that they need. And you can basically detect for MRD in the blood. It's a way to detect for very, very, very tiny amount of disease in the blood. So I think it's going to be making its way in the forefront, at least here in Miami. It's going to be coming here probably shortly after the new year.
So that brings me to my next question then. So mass spec, however you say it, mass spec. And then let me think of the three. Somebody wrote it down for me, so I'm gonna take them. So there's mass spec, flow cytometry, and next generation sequencing, and that's all different ways of testing MRD. Is that true?
Correct.
Okay.
Yep.
Okay, just wanted to make sure that we're on the same page there.
I guess I would make a slight qualifier to that, is that flow cytometry and next gen sequencing, NGS, are looking at cells, like that is what they're assessing. So flow cell surface markers, NGS, DNA in cells, mass spec, at least the technology of how it's being used right now, is looking at the proteins that are being produced by the cells.
Yep.
Awesome. Okay, thank you. So Dennis, this question would be good for you.
Sure.
When do you think we can expect the MRD test to be accepted as standard of care?
This is an outstanding question. So
I'm sorry, I'm really excited to hear Dennis's answer to this.
so we're actually already ahead of the game. This is our standard of care. So we have already adapted it as our standard of care. And I spoke a little bit about using it after the induction, after the induction phase, and to kind of guide us as to, should we go straight to maintenance? Should we do some consolidation therapy? So this is already a staple in our practice. And aside from using it in the upfront setting, we also use this very, very much in the relapse setting as well. So for example, if you take that same patient that I gave you before for the previous question, you have a newly diagnosed patient who went through induction therapy. They have achieved MRD negativity. They're on maintenance. Now, unfortunately, the disease starts to come back, and we notice that they're MRD positive and they relapse. So the way we approach, and of course, as I mentioned, myeloma has a lot of gray areas. So it also depends on how they progress. Did they progress more by imaging? So that will kind of alter how we manage the patient. But let's say for the argument's sake that where the patient progressed biochemically. So in other words, they're now MRD positive and now they're secreting a protein. Now that M spike is starting to go up a little bit. So how we would approach this patient is there's a couple of different routes. One, of course, transplant is always on the table. And that's a conversation for another day about transplant. But how we would typically manage this patient is we would give them another combination therapy, right? So we would put them on another either injections, infusions, or a combination of pills. And most likely we put them on a triplet. And then we kind of adapt the same principles that we did with the induction phase. So we would give them about 6 cycles of therapy again in the relapse setting. And then after those 6 cycles, we would obtain another bone marrow biopsy with MRD testing. Now, from this, there's 2 routes. Either the patient's going to be MRD positive or the patient's going to be MRD negative. And we feel that if a patient achieves MRD negativity again, that's very reasonable to put that patient back on a maintenance regimen. Now, obviously, we would not put that patient on the maintenance regimen that they progressed on, but there's a lot of different forms of maintenance for myeloma. You can take just about any myeloma regimen, modify it, and make it a maintenance regimen. Mm-hmm. So, right? So that's something that we tend to do in our practice. And of course, we're at the same junction in the induction setting where if the patient has a little bit tiny disease, we may still put that patient on a maintenance regimen. Maybe that maintenance regimen in the relapse setting may be a doublet instead of a single agent, right? So maybe, it would be 2 drugs instead of 1 drug. Mm-hmm. But we would adapt the same principles that we did. So again, this is just another example of how MRD testing, that we use it to kind of guide our clinical decision-making.
Awesome. Thank you so much. Sarah had a really good question. She said, is it possible to achieve MRD negativity if the first MRD after stem cell transplant was positive but low without doing any maintenance therapy? So is there any way that it can kind of go on its own?
Okay, this is a very tricky question, but I will answer it as best as I can. Is it possible? Yes, it's possible. Is it common? It's not very common. But it is possible. So sometimes it just takes a little bit longer for certain patients to kind of test MRD negative. Mm-hmm. I also want to add that we also have patients who have been MRD positive after the induction phase, transplant or no transplant, they still are MRD positive. They go on maintenance, and somewhere along their line of maintenance, they actually achieve MRD negativity. So I've seen it without maintenance in patients who got transplanted, although I'll be very honest, it wasn't very common. And I've also seen it in patients who are MRD positive, go on maintenance and then have stable disease and actually convert to MRD negativity.
That's fascinating. Thank you.
There's kind of a theory that some patients can achieve a bit of like a level of equilibrium where, because your immune system will target cancer cells, and something that's part of your body does have a response to cancer. It will target cancer cells, and so there's the kind of a theory that can happen where you can have patients who have low level of MRD that remains quite stable, or in some cases is stable and then drops, and then it may just be that their immune system is able to keep it in check, and then at some point is able to, if not eliminate, kind of drop the level of cancer down below detectable level. But we hear about it anecdotally, but it's rare, at least without maintenance associated or any sort of treatment associated.
Awesome, thank you. Stephen Morris has a question wondering if MRD tests should only be used if the regular tests show no cancer cells.
Well, so I guess if by regular test, if that saying complete, I guess if I'm going to interpret that as complete response, and in that case, yes.
So for example, I think this is what he's asking. So
Okay,
if, for example, he got a result that was partial complete response, is it even worth it to do an MRD test, or is there any case that says, okay, you should take an MRD test?
So there's quite a bit of evidence that patients with VGPR in
That's
particular,
what I meant to say.
yeah. So a lot of patients who are in VGPR can still be MRD negative. And from the quite a bit of data that a VGPR patient who is MRD negative has the same outcome as a patient who is in CR and is MRD negative, versus actually a patient, the flip of that is that a patient who is in CR but is not MRD negative doesn't really have any better outcomes than a patient with just a partial response. And so, yes, if in a VGPR based on quite a bit of clinical trial data, it is still worth getting an MRD test.
That's fascinating. Thank you. Stephanie's wondering if radiation to the pelvis affects the bone marrow MRD testing.
It shouldn't. So yeah, and it shouldn't. I will say for the NGS, at least, it is the DNA sequences tend to be quite stable through the life of the cancer. And so it seems it would be very, very unlikely that radiation would affect that. And I will say the same. I mean, the same would hold true for flow as well. I don't know of a scenario where it would impact it.
Okay, thank you. Graham's wondering, does an MRD negative report need to say at what level, for example, 10 to the minus 6?
Does it? I guess.
Will it give, like, for example, on this clonoSEQ test, will it tell you how sensitive this test was on your test results?
Yeah, so clonoSEQ says what the level of sensitivity of the test is. I guess I will refer to, I've never actually seen, for instance, a flow cytometry test report. And so Dennis, does for flow, do you know, does it say what the level of sensitivity was?
It does, yeah.
Okay.
It does, yeah.
Cool. Okay. Amy has an interesting question that I definitely would not know the answer to, but maybe somebody here does. She's asking, can someone explain the pathophysiology of the situation when someone is MRD negative but has evidence of radiographic myeloma disease?
So,
well,
go ahead, Mark, I'm sorry.
Well, no, I mean, you actually might be. So, actually, do you call it extramedullary with myeloma? Okay. Yeah, I mean, so sometimes there is disease that develops, it's rare, but there is disease myeloma that develops outside of the bone marrow. And in that case, a bone marrow test is not going to pick it up, whether that is clonoSEQ or flow cytometry, but it would be picked up by imaging or potentially by blood assessment.
Yeah, and I'll just piggyback on that. So I know we're talking a lot about bone marrow biopsies, but one thing we're not talking about is imaging, but this is not an imaging talk. But I just want to kind of point out that when we restage after induction therapy and after we do our annual bone marrow biopsies on these patients who are on maintenance therapy, that we're always doing some sort of imaging as well. Our go-to is usually a whole body MRI without contrast, or we do whole body PET CTs. So I just wanted to make that point.
Awesome, thank you. It's time to finish up now. I know we didn't get to all of the questions, but I do appreciate the team here for answering the questions that we did get to and for this information that was shared tonight. I am learned actually quite a bit tonight, and I am excited to move forward with this information. So thank you, Robin, Mark, and Dennis for sharing your time with us.
Sure.
We're going to be finishing up with just a couple of outro announcements, and then we'll be done for today. I'm really excited about sharing this upcoming event that we have. It's very special. We have the privilege to hear from Dr. Jim Allison, who is an immunotherapy pioneer and a Nobel Prize winner. His unconventional thinking led to the treatments that we now know as immunotherapy. So if you have gotten any form of immunotherapy, you can thank Dr. Jim Allison. You will have the opportunity to watch his documentary for free and then come to ask him your questions on November 15th at 3 p.m. These slides will be sent out to you today, so you'll be able to click right on that link and register in order to meet Dr. Jim Allison. So we're excited to host that event in November. You may be interested in other Myeloma Crowd community events we have coming up. Tomorrow we have two very special events. One is at 2 p.m. Eastern, one is at 2 p.m. Mountain, which is 4 p.m. Eastern. The first one is the African American Myeloma chapter, and we're going to be talking about the importance of clinical trials from Dr. Craig Cole. The next event is going to be our nutrition and wellness for myeloma chapter. We're going to be hearing from a dietitian at a cancer specialty center who will be speaking to us about how to manage our side effects with nutrition. And then the second at 1 p.m. Eastern, we'll hear from Diana Valentine, who is our myeloma financial coach, and she's going to be coaching us through creative ways to find life insurance even with cancer. The link to sign up for these events and even more events that I have not mentioned is found at the bottom of the slide, and it will be sent out in the follow-up email within 48 hours of the event's conclusion. Again, another thank you to our sponsors, Bristol Myers Squibb, Takeda Oncology, Karyopharm Therapeutics, Adaptive Biotechnologies, Oncopeptides, Janssen Oncology, AbbVie, Sanofi, Amgen Oncology, and Genentech. And thank you to each of you for attending tonight, for participating. We appreciate you so much and hope that you have a great rest of your day. Thank you, everyone.
Thank
Thank
you
so
you.
much.